This conference will now be recorded.
Good evening, everybody. This is Rick Davis in the AS group, no less, the early AS group. Today is the 14th of, is it? No, it's
The 9th.
It's the 9th.
it's the 9th. Oh, I'm looking at Mondays. Today's the 9th of April. And we're turning the recording on a little bit late, so you've missed a little bit, but there still should be plenty of good stuff to talk about. A quick thank you to our sponsors, who are Johnson and Johnson. Not Janssen. It's not Janssen anymore. They don't call themselves Janssen anymore. They now call themselves Johnson and Johnson right the way through. Bayer, Myriad, Telix, Blue Earth, Novartis, and Foundation Medicine. Did I get everybody, Mr. Tosca?
Yes, you did.
Okay, thank you. And we also want to mention that we don't provide medical advice in this group. This is all based on peer experience. But we may sometimes suggest to you that you go check some stuff out with your healthcare providers, because you're going to hear good stuff here that you might want to take back. I am now going to turn it back to the moderators, because I'm not an official moderator. I never was on early active surveillance, unfortunately. I wish I had been.
Thank you, Rick.
Thanks, Rick.
So we have a new person. Was Gary? Do you need any time this evening? Welcome.
Who's that, Eric? Who'd you ask?
Gary Ireland in New York City.
Gary Ireland's one of our moderators, actually.
Oh, is he? Oh, okay. My bad.
I'm all set. Thank you very much, though. I'm sorry I was late. I had a conflict.
Got a caller one, Eric?
Oh, yeah. Caller one. Do you need any time this evening? Welcome. Okay.
Would you like to identify caller one? Would you like to tell us who's on there? I know it's not Henry. That's who usually is on the phone, but he doesn't come to this group. But if not, you're very welcome to stay and pipe up if you want to say something.
All righty. Well, I think we should welcome again Martin to the group, and I'm sure he's had a little bit of time to get his history together. Again, welcome, and I see you're from Chicago, correct?
I am.
Excellent. And how did you happen to hear about ANCAN?
So I talked to, I reached out to, after my prognosis, I reached out to see if there are local support groups, and I talked to James Schrader, who recommended the group. He said to say hi to a number of folks, so hello. If I'd have known we were recorded, I would have been caller 2, but we're good. So I'll start with a history, and then you can redirect me if I'm going too slowly or too quickly or irrelevant details. So
well, let me ask a few more questions.
Go through the list. Yeah.
By any chance, are you a veteran?
I'm not.
Okay, because we have a veterans group that might be of interest. Okay. Well, I'll tell you what. You can start. I would be asking you where you were first diagnosed and where, when, and where. So go ahead.
So I had a TERP in October of 24, and as part of that, they took a sample and they found cancer in 5%. So then basically because of the TERP, you have to, things have to settle down. So they didn't, I had an MRI. The MRI actually happened in February. And I have the PIRAD score, but I think the biggest thing that happened from the MRI, they noticed a, looking for the right word here, lesion. But from what the surgeon who did the transperineal biopsy said was like, that is the only area that didn't actually have anything in it. So I have the PIRAD score and all that from that, but it seems like that's superseded by the biopsy information.
So you had
So
a TERP or a transperineal?
I had a TERP in October where they took a sample, and while they were doing the TERP and they found cancer. Then I had the MRI in February of 25, and I had the biopsy, transperineal biopsy in March 28th, and I just got the results of that back.
March 28th of this year?
Yeah.
Okay. So there was 3 years between your
Oh, it was 24 and 25. So October of 24, I had the TERP. February of 25, I had the MRI, and March of 25, I had the biopsy.
Okay. All right.
So
And the
like just got the results basically like last week.
and what was the Gleason score?
Gleason score was everything was in. I guess the way to you can direct me on this, but looking at the report, they did a whole bunch of samples. The the first was a 3+3, which is 6, grade 1 of 2 cores, 10% involvement. The second was a 3+3 equals 6, group 1, 2 of 3 cores, 40% of core. The third didn't show anything. The fourth was 3 of 3 equals 6, 2 of 2 cores, 40% of core. The next was 3 plus 4 is equal to 7, grade group 2, although it is a little unclear because they say the focus of the tumor is too small to assign a percentage of Gleason grade 4 tumor present. Involves 1 of 2 cores, and it's 1 millimeter, which is obviously, in my opinion, a very small amount, but 10% of core involved. And then, just reading here, the left side had small focal of atypical gland suspicious for malignancy. No other details on that. And then left posterior, I guess all of these I could have said where they were, but this is left posterior lateral, no malignancy identified. Left anterior medial, no malignancy. The same with the anterior lateral, no malignancy. And with the prostate region of interest 1, no malignancy identified, which I think is the lesion itself.
Okay, so you've got 3 plus 3 6s, 1 at 10 and 2 at 40%, and 1 3 plus 4 7, but it was so minute they couldn't even grade it. They didn't give you a volume.
That's correct.
Okay, all right. And where did you have this done?
So local Euro Partners is actually a pretty big operation here in Chicago. They have a surgery center. I had it done there.
Okay, did you get a second opinion on your slides yet?
I did not. That's the next step. I actually talked to James directly, suggested that. I'm just trying to figure out where to get that done.
Okay, well, we have a couple of suggestions, and Eric can give you the put in the info. We like a Dr. Ming Zhao at Mount Sinai in New York, and
Okay.
also Jonathan Epstein is back in business, I believe, in Long Island in New York, but one of the boroughs. I believe he's in Long Island. And you can send it to Hopkins. Hopkins up in Baltimore. They will do a reread also. That's the first thing that we would suggest. What was your PSA history when you started on?
Yeah, give me 1 second. I can give you that. It's not. I mean, it wasn't too spectacular. Let me look at the trend. So it was in 2019. It was 242. In December of 2020, it was 194. In February of 22, it was 3.06. In February of 23, it was 2.47. October of 23, it was 2.51. And March 14th, 2025 was 3.77.
Okay, that's
pretty narrow range.
Yep,
Yeah,
that's a real narrow range, close, low, not too much of a concern there.
And you mentioned BPH. That's originally the reason I went in for the TERP
Turf.
in October. So
And how did that turn out for you? That particular procedure, did it
it turned
sit
out
comfy?
pretty well. I had scar tissue, so they had to go back in after about 3 months later to clean it up again. Not a returp, but just get rid of the scar tissue and like the channel, if you will, the urethra. And after that, so far so good.
What kind of turp did you have?
Uh, I didn't know there were different kinds of terps.
Oh yeah, there are.
Okay, let me see if I can get more details on that then.
Isn't that just basically the rotor-rooter process?
Well, it is, but there's so many different ways of doing it.
I see. Mechanically versus laser
Well,
versus.
exactly. There's laser.
So yeah,
There's
so
heated
I think
water. There's like
I think it was ablation was what I remember. Oh, I can get more details.
Sounds right. Aquablation.
Yep, I don't see it here in front. I'm in my chart. I don't see the
so
details.
aquablation is the resume treatment, I think.
I believe you're right.
The have you had any genetic or genomic testing, Martin? Did you
Uh, that's a great question. So beside this, I have SCAD, which is spontaneous cardio artery like dissection. So generally, it's 90% of women have that, but then I do, of course. So I have that going on too. I've had genetic testing for that, and I'm a carrier, but I don't actually have well, I guess I have it because I'm a carrier, but I'm not affected by it.
okay? All right. Um, okay.
Kind of family history.
Now, yeah.
Question, I talked to my cousins. My father died in his 60s, so we don't have a whole lot of history there. His father had heart issues, but I'm not aware of any prostate issues with him. He lived till about 83. So unfortunately, not a lot of family history that I'm aware of or people that are alive to tell me about it. You don't know
How
you need it till later, I guess.
how the we always talk about anxiety because everybody, although you started with this TERP BPH situation that evidently seems to be working out for you. Um, Anxiety on a scale of 1 to 10 on a daily basis. Now that you've been, recently, well, this last month rather, having this new biopsy. Does it?
Yeah, I mean, it's
Does
only
it?
been about a week or so since I found out. Probably, I don't know, 2 or 3. I guess
Okay.
there's some, I'm reading through, some resources on, what possible, like obviously surveillance is one, surgery is another,
Oh, oh
radiation
yeah.
is another, like the list goes on, right?
Yeah.
But
Yeah. It
it
does go
seems
on.
like there's a lot of, I don't know, the summary I had is there's a lot of uncertainty which one of those you should do. There's ramifications for all of them, and you really
Correct.
don't, even if you go like, we're going to remove it, you don't know until they do the full pathology to know kind of what happened there too. So I guess that's what I've been wrapping my mind around most recently is just seems like there's a large amount of uncertainty around this.
Yeah.
One of the
This is
things I think I feel fortunate about having this particular disease is we have time to do the research. You can join this group,
Yes,
for
yes,
example, and
yep,
get feedback and then go out and do your own research, ask your doctor. Generally, unless there's extenuating circumstances, there's not an urgent need to take immediate action. So that's where I feel fortunate.
I agree. Thank you.
yeah. And the other side of that coin is just as you stated. I can state 10 different ways that you can get treatment, all of them with their own ramifications. And how do you find which one would be the best fit for you?
Yep.
Which is difficult. So hopefully you hang with us on active surveillance because it doesn't. It looks like you're a great candidate to hang out with us for a while, and would love to have you come every Wednesday and keep us informed as to what's going on. We do need your email so we can send you the meeting notes So if you would, you could send that. Do you know how to use the chat window up in the
Yep.
top right? If
Oh,
you would send that to Eric,
okay.
and he will pass that along to people, quote unquote, in our office that will make
Okay.
sure you get all the correspondence.
Okay. Sounds good.
Now, the second opinion would be the first step that everybody on the screen would certainly agree with, to
Okay.
make sure that everybody's on the same page and feels the same way as to your findings to this particular point. Do you have any specific questions for anybody in the group? Um, Anything that we can answer? Eric, have you got anything for Martin? I think he's right where he should be.
Yeah, welcome and thanks for joining. I'm glad you're here, and we support you as best we can. And if you have any questions, don't hesitate to reach out to us, even off camera.
Yeah, I guess the one question I have, and then I'll yield the floor because there's obviously a number of us here, is for the email address for Dr. Zhao, just reach out to him at that email address and say, I'm looking to get a second opinion, and that's all it takes, and then it'll kick the process off.
Yeah, he's good at that.
Okay. And then how long does it generally take once he gets them?
There's some logistics because you have to coordinate with your lab that has your slides that then have to be probably FedExed and all this and releases and yada, yada, yada. So figure a week to get your slides there, a week maybe to get them read and returned. So probably 2-ish weeks for a report to show up.
Yeah, they're pretty quick once you get the ball rolling from the lab that's sending the slides. They read them within 5 business days normally.
With my original slides, it took a little bit of doing, and I think there's not really a financial incentive. I don't think they make money off sending slides to it for a second opinion. So I just kept on them, respectfully being persistent.
The
So,
original folks that had your slides, you're saying?
Yeah, I got my slides done, at NYU, and I wanted them sent. I would have had a second opinion no matter where I was, but it
Sure.
just seemed like there was unnecessary confusion. I'm like, hey, just please send the slides, and I was much more respectful than I was just there.
Yeah. Okay. Makes sense. Thank you.
Martin, do you know where your slides are?
I don't. I'm assuming that Euro Partners has them, but that
Yeah.
once I reach out and find out where they're going, I'll kick off the process of reaching out to them, which I'll probably do tomorrow. Honestly, I'd like to get this
Yeah, if
started.
they don't have it, then the lab will have it. If they use
Okay.
a lab to.
yeah, so here's what I would suggest. Work at it from both ends. Reach out to Dr. Zhao. I see we've got a bunch of hands up, so forgive me for jumping in, but it's right on topic. Reach out to Dr. Zhao, and at the same time, reach out to Euro Partners and tell them you want to send your slides to Dr. Zhao at Mount Sinai. And if you work at it from both ends, it'll happen a lot quicker. Okay. The other thing I wanted to mention to you is that you can have you ever had any genetic testing for inherited mutations?
Only for my heart condition that I described, but not for anything else.
Okay. So you can right now, it's still available. You can get a free test as part of a clinical trial that's sponsored by Johns Hopkins and University of Washington, Fred Hutchinson. I've put that link in the chat window for you.
Okay,
They're
great.
getting very close to their capacity of 5,000. They're pushing that 5,000 limit, but they're still taking new people. Use that link. Just click on it. It'll open up in your browser and you can go to it later. Order the test. Don't ask them to send anything to your doctor. Have them send it all to you. And you will have a germline test within 4 weeks at no cost to you.
And that's the Promise study that you dropped a link to there?
Yes.
Okay, perfect.
Thank you. I pinned it to the top for you.
Thank you. I appreciate it.
All righty, we've got some people with their hands up in order. Derek, what do you got?
Yeah, I just want to say, Martin, welcome. Kudos to you for joining the group. I know that when you first saw those results, that was heart stopping for you. And I just can want you to rest assured that you're in the right spot, you're in the right place. These guys know what they're talking about with these numbers and where you're at. And yeah, there's no rush to run any hasty decisions at this point in time until you get further testing, diagnosis, and you got time. I did want to ask you about your TERP or your BPH. What type of symptoms were you having prior to?
I mean, basically very slow flow and slowing. So that was the concern, right? And almost like an anxiousness because of that. So that was the condition. And I didn't really. I'm 58, so I was like I'm young enough to have a treated for it, and I'm not super thrilled about medicine. So I was like I would opt for surgery over taking medicine for an extended period of time.
Gotcha. And how fast did those symptoms come on for you? Was
Yeah,
it
that's a great question. I would say in probably a year it was slightly annoying, but the last 3-4 months it was getting progressively worse, and I was getting up to go to the bathroom n number of times a night. So it seemed like the last 3 months before it seemed like it was getting more challenging.
would you consider your process a success at this point?
I would, yes, yep.
Procedure. Okay, thank you. That's all I got.
All righty. Andres, you got a question for Martin?
Yeah, well, question and comment. Well, welcome, Martin. I just did submit the promise study application, and the response was they're closing the study on the 11th. So if you're interested, maybe you should just do it right away. And I also want to thank Eric for the form that he posted last week about the second opinion. So I followed that form, and there was a little bureaucracy getting the permission from the lab and from my doctor, and then Wayu Langon, and then they send it back. So now I'm awaiting the results. My question for you all is how a second opinion can differ from the original diagnosis. I mean, it's the first time I'm going through this. How, I mean, I understand that it might happen when people go to community hospitals versus center of excellence, and maybe a different reading. But is a reading so different from one another that you can have different Gleason scores, or
Yeah,
Yes.
yeah,
yes.
Yes.
Absolutely.
They
That's why
could
you do
they
the
could
second opinion.
downgrade. Hopefully they would downgrade. Let's say if you had a 3+4 at say 5% or 10% or 20%, they might downgrade that to 3+3 6 Gleason. Unfortunately, it works both ways. You could have two 3+3 6s that they now say they're 3+4. Most probably would be a low volume number, 5 or 10%. But hence the reason we have the second opinions and why we go to specialized people that look at nothing but prostate pathology. That's why we send people to Ming Zhao and to Epstein or to John Hopkins, where Epstein was for decades. So that's so it's very critical. We speak all the time about second and sometimes third. If you got a conflicting second opinion that brought, if it was hugely different, we may say, well, you know what? Maybe you need to have someone else even look at it. And we say the same things about MRIs. And luckily enough, in the world of uh, micro ultrasound, thanks to Phil, we've got somebody to look at some of those. So as time goes on and micro ultrasound becomes more rapidly available and used, we should have a number of people that are specially trained and evaluate those particular scans. So but that's the story on a sec. I mean, that's why we do it, just to concur or to see if there's a difference. Hopefully, as I said, it's always great to have something downgraded rather than upgraded. But you need to know that information, because active surveillance is just that. You have to be active. You have to be your best advocate for yourself and become as informed as you can. Hopefully, this group helps, because that's what we're here to do. Everybody's on the same journey. Everybody's going down the same river, just taking a little more time, or taking a little bit, stopping at a few more destinations. So this is, we're all here together for each other. So that's what we do about second opinions. Did anybody else have a question for Martin?
Yes, Phil does. He's had his hand up.
Yeah, it's not really a question, but Martin mentioned an issue with his heart, and Derek mentioned the word heart stopping about the diagnosis. So this is somewhat relevant. ASPE is having a webinar at the end of the month. The biggest threat to the health of prostate cancer patients, heart disease. So, I mean, it's going to be I know the speaker is he's really good. So I just put the name of the webinar and the link for those who are interested.
And we'd also like to add that normally we talk about diet and exercise. We certainly say that exercise has been proven in various studies, regardless of the type of cancer you have, exercise is good. I mean, we all kind of know that from just basic living, you need to stay moving and get exercise. Diet has always been an issue. We have different people that adhere to a strict diet, some that don't do so much. There has been studies and basically wrapped around the Mediterranean diet, which is the heart healthy diet, which circles back to heart disease, which kills more males than anything else, kills more people than anything else. So when we touch on diet a little bit, but it's the Mediterranean diet. But there's other people here that have taken certain supplements, stopped the intake of sugar, done a lot of different things. And again, you're your own best advocate. That's up to you. A lot of people have have gone on a modified their, I hate the word diet, modified their behavior in a weight loss situation. And that seems to have helped with PSAs in some cases, but that's most probably definitely an individual thing. There's no study saying, okay, lose 50 pounds and your PSA is going to go down. No, that doesn't work. But just basic knowledge, and I guess what we try to say is, yeah, heart disease is a biggie, and right in line, you need to be aware, and the two kind of interlink.
What's good for the heart is good for the prostate.
Bingo.
Many hospitals have alternative treatments. I go to a nutritionist at MSK, Memorial Sloan Kettering, and they also have acupuncture and other things. But once you get in the fold, it gets more comfortable to reach out and get these other support systems. And I do yoga almost every day, and it makes a huge difference. Plus, I'm usually one of the only males in the class, and I'm twice the age of everyone.
It was my early day in aerobics, the same thing. I was the oldest guy and the only guy, and that was.
My daughter refers to me as a triple minority.
Very, very sad, but I enjoyed it when I did it, and of course that was many years ago. Okay, and of course, Martin, that's got to do with stress. Yoga, meditation, Tai Chi, those kinds of things have been proven to reduce your level of stress. And then, of course, stress kills. It's that simple. People get wound up like a rubber band. Something's going to give. And of course, when you're diagnosed with cancer, that can twist a rubber band kind of quick. So you want to make every effort. And as Gary alluded to earlier, unless of extenuating circumstances, none of which you have described, you've got time. We've all got time to do the research, time to get in a peer group like this, time to explore a lot of different avenues. And we have different groups. If somebody was thinking about getting a certain kind of treatment, ANCAN has a group where those people have either undergone that treatment or thinking about that treatment. And you can talk to somebody, live and in person, like all of us here, to get the real scoop on what's going on, not just to read something in Google or, wherever. Is there anything else that we can do for you? Any other questions? We certainly, again, a deep, heartfelt welcome. Thanks for sharing. We appreciate that. And would certainly love to see you back every Wednesday, except the fifth Wednesday of a month, which we happen to have 5 Wednesdays this month. There will be no meeting. And also, we record on the second and fourth if you have any kind of issue about the recording part, as Rick explained.
Yeah, I guess the only question I had is like, you talked about second and third opinions. My concern is I'll get 3 different opinions, they'll be different, and I'll be like, what am I going to do with this? So if this expert is the second opinion, maybe that's, I don't know, sometimes too many choices make it not, make it harder.
It's all about a shared decision making with your doctor and discussing all those numbers. Who has the golden eyes of the pathology, like Zhao or Epstein, versus your local center and things like that. And just have a discussion about all of them and make a wise choice based on those tests.
One of the problems, I wouldn't say a problem, one of the features of having this disease, we have all based decisions on that first pathologist that looked in the microscope at those slides. At that point, with that person that you never meet, he springs this on you. Depending upon your local doctor, of course, we have a lot of problems with how they talk about it to start with too. But you don't want to put all your eggs in one basket, I don't think. That's basically what we're saying. And normally, when you're talking to 2 experts, hopefully they're going to be close. Somebody's not going to say, "Oh, you got a 4 + 4. We got to do something." When you were diagnosed with a 3 + 4 or 5%, that I don't think that's even possible. That there would be that range in between. It's just making sure. I mean, we are definitely proponents of the second and third opinion because everything is based on pathology. So you definitely want to have at least one of them concur or not be far off from the first person. And of course, if somebody has gone to a small center where everybody it's all owned by the same people, and they send you next door to my buddy, go see Bob, he's going to do this or he's going to do that. We kind of shun away from those kind of practices too, because sometimes you need a new pair of eyes. You need a fresh look. Your particular situation at this point, just a second opinion on the pathology is the way to go, and then take a look at it. And as Eric said, discuss it with whoever you're seeing, and see if it all adds up, and see how you feel about it. And of course, come back and tell us, and we can always, hopefully help you out and inject some thoughts as to what they're telling you or what they're not telling you. So,
to reiterate what you said, and what I learned from this group was and you were saying was, if you get a second opinion, go outside. Like I was at NYU. Well, I got a second opinion at one of the other centers of excellence to make sure that there was no connection. I think that was great advice for me.
Okay, Martin, is there anything else we can do for you?
I don't think so. This has been hugely helpful. Thank you.
Okay. Well, we certainly, again, a warm welcome. Thanks for sharing.
Thanks, Martin.
We hope to see you.
And Derek has a question. Has his hand up.
Thank you, Eric. I just, Gary was almost there. I want another plug for ANCAN. There's another group that we have called Men Speaking Freely, Martin, that we sit down and we talk about our feelings about dealing with our disease. Not the technical side of our disease, but the emotional side and the family side and the support side of it. And that's something you might want to consider as well.
Okay.
Men Speaking
talk
Freely.
about my feelings, so that'll be good probably.
Yes, it is. Absolutely. Absolutely.
They talk about everything but treatment.
Correct. Anything and everything but treatment.
Yeah. And Rick.
I'd like to talk about how my football team, my soccer team did last night, and you can talk about that in Men Speaking Freely, but you can't talk about it in here, especially when we're being recorded. So I won't. Now, What I really wanted to say, because you raised a really good question, which is what happens when we get these opinions? How do we process these opinions? How do we know where to go? One of the reasons we create this type of support group, because we're a lot different to many other groups. We're both supportive, but we also give you a lot of good technical advice. We have good information. We pride ourselves on providing good information. We have some expert moderators, is because we can guide you so that you're not just sitting there thinking, oh, Dr. A says this and Dr. B says that. We can help you understand whether what Dr. A says is valid and you should rely on it, or whether there were maybe errors. So, for example, if you get a biopsy that is not a fusion biopsy, I think we asked you that. Was yours a MRI fusion biopsy with Euro
Yeah.
partners? Yeah.
Yes.
So, but we've had guys just recently come in and they didn't get fusion biopsies. So then we're saying to them, well, you can't really rely on that biopsy. So we can help you sort that through.
Yep.
Second
Okay.
thing that we tend to, I don't want to say rely on it, but it's kind of a tenet, is that we're very suspicious throughout all of our groups, from the lowest to the highest, of doctors that don't practice in centers of excellence. Now, that doesn't mean to say they're bad doctors. And they may be very good doctors, and they may make the same decisions that doctors in center of excellence may make, but particularly lower down the treatment rung, there's a lot of conflict of interest in medicine, particularly in the United States. Especially in the United States, there's a lot of conflict of interest. Phil doesn't have the options we have, but he doesn't have to worry so much about just being treated for the sake of being treated. He may get treated by he may not get treated when he needs treatment, because they may be being parsimonious on treatment when they shouldn't be. That happens in national health systems. But he's not going to get pushed into a treatment that isn't necessarily the right treatment for him.
Okay.
Now, even with somebody like Europartners, and yes, they're very big, you've got to be careful that you might be a great candidate for active surveillance. You've got no risk, 3+3s, whatever it is, and they're going to want to do surgery, or they're going to want to do radiation. And they're going to turn around and say to you, oh, well, you're a young guy and you're 3+3, but we definitely think you've got to get this out. No, you don't. Ask Eric. So, and we've got those peers. So you can come here and you can talk to a peer like Eric, who's younger than you are, who has more cancer than you have, and who's sitting here doing active surveillance and comfortable doing it. So we want to take that, we want to minimize the stress over which opinion to take and who to listen to. We can't give you the medical advice, but what we can do is guide you to the best people to navigate you.
Okay. Yeah. One thing I didn't mention is I'm talking to somebody at Northwestern Medicine downtown Chicago, which I think is a center of excellence.
It is.
So I'm talking to a surgeon who will probably give me a surgeon answer, though.
Well, but you see, we would say to you, don't talk to Northwestern.
Oh, really? Who would you say talk to?
And the reason we say it is because Northwestern are cutters, by and large.
Yep.
That's their background. That's what's his name? The guy Edward Schaefer.
Yep.
That's Schaefer's philosophy.
Yep.
So when we come across people and they tend to be looking for second opinions, we'll send them to centers of excellence. But we don't love Northwestern, because Northwestern tends not to favor active surveillance. When we have a guy in your situation, we want you to go to somebody who we know will recommend active surveillance if they think it's the right thing to do. And our experience has been that, yes, it can happen at Northwestern, but it's not the best. We would say either go down to U of C, even though it might not be the most convenient, and go see somebody like Egner, or go to Helfand at it's on the tip of my tongue. I'll tell you in 1 second. But these are really excellent docs, and we know that they North Shore. Go to Helfand at North Shore, or Egner at U of C. These are people that we know if they think that you could do active surveillance, they're going to support you in that.
I had the same concern. I went to a surgeon, but he was known to be supportive of active surveillance. I'm very comfortable with him. He has made no saber rattling that I should be treated yet. So I'm quite comfortable. But I certainly hear the concerns, and I shared them I shared them with him.
All right. Well, that's actually another really useful piece of information. I'm just looking at nci.org. So are these centers of excellence? So University of Chicago, is there a particular person you mentioned? How do you spell that? Or is there a link you can drop?
Eggener, Egner. I'll put a link in the chat window for you.
Okay.
I'll put a link in, and Helfand, Egner knows us real well. Helfand knows us real well. And another thing to do is sign up for the Active Surveiller. Can somebody put Howard's Active Surveiller link in the chat window for Martin? Howard's in Chicago. He's very, very, very knowledgeable. He's been on active surveillance forever. He knows all the best active surveillance docs. He loves to talk to people. So reach out to and have a chat with Howard about. Howard is a moderator, but he doesn't attend so regularly anymore. He's also on our advisory board, and he has a very successful and large now blog called The Active Surveiller, where he writes about everything and anything to do with early active surveillance.
And he's from Chicago.
Okay, there we go.
And he has a luncheon group, so he'll be anxious to meet you and have some lunch. Ken in Chicago has joined Howard for lunch. He always picks out some interesting place, so you can. That is an excellent source of information. Hoping you like to read, because Howard loves to write. He loves
He's
to
filled
write.
with knowledge. I mean, he's really filled with knowledge.
He is absolutely unbelievable.
Yeah, he was the medical advisor. He was the medical writer for the Sun Times for many, many, many years. So
I just posted it in the chat for all to see.
Yeah, there you go. So you can. It's free. You can run. He'll try to get money out of you. If you want to give him money, you can give him money. He asks more often than we ask, and he's not even a nonprofit. So, but
it's a very low amount.
Yeah, it's a very low. Okay, see,
worth supporting.
Yeah, it's well worth supporting. He does have to pay. I don't think Howard's making any money on it. That's for sure.
Well, let me put it this way: he's not retiring anytime soon.
Yeah,
he's retired, but not retired.
He's not even out of college yet. He's finishing his degree.
Listen, neither are we, but I don't hear you telling people that you should be sending money to us, right?
Well, you said that already. I caught it. I don't know if anybody else caught it, but I caught it. I caught what you said.
Okay. So here you go. Here's Scott Egner. There's Scott Egner. I just put him in, and Brian
Helfand is at
Helfand.
Northwestern, right?
No, Scott Egner's at University of Chicago,
I meant
and
Helfand. He's at
and
Northwestern.
Helfand, who's equally as good, is
North,
another option for you.
North Shore,
Yes, North Shore.
Endeavor Health.
Oh, okay. Yeah, I have my primary physicians through Northwest Community Hospital, which is now part of North Shore, so that might be an
Okay.
easy path.
So yeah, tell him you're an ANCAM person. It'll mean something to him,
Okay.
and go through your PCP, and go to Helfand or go to Egner.
Anything else? Because we got other people wanting to.
Yep, we've got a few people left here.
Done. Thank you so
Did,
much.
Okay,
did John
Martin,
wanted some time?
Yes. Hello. Sorry. Let me come on. Hi, guys.
Hi, John.
Hi there. Thank you for last week's meeting. It was my first official meeting there, and I just wanted to bring up a few points. I did an MRI session last Friday. That was my second MRI anniversary of my last, and this was done at UCLA, and I was kind of disappointed. They put a needle on my right hand, and then in the middle they came out and said that it fell off. So then they did my left hand, and then the noise was excruciating, and I asked for classical first, and then I told them to do rock and roll, and that still was, I don't know, 15% of my attention. It was just like weird. And then on the second part, like they came back and said it I didn't get enough dye, and then I guess the guy that looks at it, whatever his title is, he decided at the end that I did get enough dye into my system, and but then since Friday I have no results, and my question was, is that normal that you would not get a result in what, 4 days now, 5 days now?
Yeah, it depends on how backed up the radiology department is.
Did you
Oh,
say
okay,
UCLA, Bijan?
that's correct.
And was that the campus or a satellite?
It was I guess it would be considered a satellite.
Outside of Westwood?
Yeah, but it's in Santa Monica. It was in Santa Monica. So,
Thank you. Interesting.
so yeah, that was a little bit weird. And then I also wanted to, for the benefit of Martin, um, four people, doctors, including my primary doctor and my cardiologist, have told me that surgery is what I need to do. And there's only one holdout right now, which is under is Tim Wilson's group in St. John's in Santa Monica here, that is an active surveillance advocate. And as a matter of fact, tomorrow night at a private residence here, he has some sort of a meeting going with his oncologist, apparently, which they sent an invitation. So I said yes. So it's just, the people that want to do surgery, and at least around me, have been most of the people. So that's, I wanted to share that.
So just remind us again what your disease demographics are, please, BJ.
Excuse me, what's the question again? Sorry, the dog is barking.
Your
It's
score.
okay.
Well,
Please remind us again what your disease demographics are. What?
You mean? Oh, I was diagnosed with Gleason 3+4
Mm-hmm.
with 5% being 4, and I think Eric looked at my results as well, and so it was 5% on Eric. I was trying to educate
Yeah,
myself.
I'm
How
gonna
many core? It's okay. How many cores?
Do you remember, Eric?
I'm gonna look it up real quick. So a second.
It's my
And
gut.
Maybe 9 thereabouts.
Uh,
9 cores?
Does that ring a bell, John?
I don't know. 'Cause I don't. I'm afraid I don't keep notes on your AS guys, on the AS guys. And
Looks like
is
maybe 9 3+3s, and I didn't write
nine
down
three
any
plus
3
threes.
plus
So
4s.
that sounds about right.
and 1 3 plus 4. So
Two.
and
I think it was 2+3.
who's the surgeon at UCLA that's telling you need to get surgery?
Actually, UCLA is the head of the guy that I take that back. He agreed with Wilson saying that he's okay with active surveillance.
Okay.
So
So yeah,
he's
so
actually
let's
number
not go
two.
any further. Let's not go any further. Don't go to do you need to go to the meeting tomorrow? Because the more you can make yourself crazy here.
No,
You've
no,
got
the meeting tomorrow is with Tim Wilson, who is on his team for active surveillance.
Well, I
So
know, but even so, the more you hear, and then you get worried, and you put yourself in that situation, and then and, you make yourself sugar. I mean, it's like I don't want you to do this. What I want you to do is take the confidence that Wilson says yes, I should be doing it, and especially if you're going to be going listening to a medical oncologist who's going to be talking about much more advanced stuff that's only going to make you more worried. I mean, there's a reason why we don't talk about a lot of this stuff in this group because we don't want to create anxiety. We can talk to you about it. We can talk to you about all the things, but you want to go listen to radionuclide treatments and for somebody who's got advanced disease? You don't want to know that right now.
I think you got a really good point. But as I mentioned last week, I
Yeah.
am in like a really weird psychology mood. Is that I'm still in a mood of um, denial. At the same time, it's sort of like, I had the whole 6 months of feeling sorry for myself and this and
Right.
that. So the anxiety factor is not there, thank God, and I hope I'm not bringing it in at all. But I think I'm naturally an extremely curious person. My wife thinks I'm
Okay.
way too
Listen,
much, so I think that's part of
BJ,
my thing.
if you feel you can handle it, you know, go ahead. Go ahead. But what I'm saying to you is, when you present to us, well, everybody's saying I should do surgery except one guy, and now we start digging a little bit, and maybe that isn't the case. The fact is, you've got 5% of 4. Yes, you've got a lot of cancer, but so does Eric. Eric's sitting there with 11 out of 12 cause positive. If you have the gut to be able to handle active surveillance, which some people don't, and that's fine too. But if you have the, I'll say the kishkas, help me here,
the
huh?
the chut.
Wherewithal.
Huevos.
Yes, in huevos. If you have the wherewithal to do it, then I would like you to think about, okay, I'm going to do it. I'm going to do it with a really good guy. If Wilson is supportive, that's great. If your UCLA surgeon is supportive of active surveillance, do it with him. But you have to do it the way Eric's doing it, which is lots of active surveillance, staying on top of it, coming to this group so we can keep supporting you. 6 months from now you'll be here. Maybe you'll come twice a month or something, and we'll be stroking you and supporting you, and you'll feel good. And that's what we're about. That's success for us. Okay. Then if you decide, well, you know what, maybe it's moving the wrong way, maybe I should get treatment, or maybe I can't deal with it anymore, maybe I should get treatment, you can go. You've even got Dr. Mark Perlow in Sherman Oaks, who you can go down and talk to. He leads the low intermediate group. He's very, very well connected. He's not a urologist. He was a fertility endocrinologist and surgeon. He's retired now. He's very tight with all those docs at UCLA. But that's where we want to get you.
And
Okay.
you've also got time. I think we talked about that before. Gary mentioned it, and I mentioned it also. You've got time. You shouldn't feel any pressure from anyone or yourself. You need to kind of try to get separated from the pressure side because it doesn't exist. The only pressure you got right now is self-induced, and that's what Rick's trying to say. It's not necessary. It's necessary to keep active, keep with us, keep researching yourself, but you've got time. And that's important. I think that can be very soothing in a sense, knowing that you don't have to rush out and make any rash decision. That way, when you do make a decision, whatever that be, hopefully to hang with us for a while, you'll feel confident with that and more comfortable because it is important. As Rick said, some people can't handle it. There is a lot of overtreatment because men just can't handle the idea they've got this disease and somebody says, "Oh, I can take care of it. We can get rid of it," and they're lying. But people fall for it and they do it. Somebody's got their hand up.
Thank you.
Derek,
And you mentioned St. John's. Was that are they a Providence or UCLA? Do you know?
Yeah, the Providence apparently bought them, so they're called Providence St. John now.
What were they offering for you?
It's Tim Wilson's group, who is he has an oncologist part of his group, a few others, and they're the ones that talk to me about active surveillance. So that's the one I was talking about.
Okay, thank you.
Look, as long as the doc is pro AS, then it doesn't matter if he's at St. John's, he's at UCLA, he's at USC. If he's reputable and he's supporting your AS. If he's not supporting your AS with numbers like yours and trying to rush you into treatment, then you got to step back. So I'm not suggesting you switch him. I can't give you. I can't suggest whether you're going to be better off with your who is it? Do you recall who the surgeon is? The name of the surgeon at UCLA?
He's the head guy, Reiner or something. Rainer.
Okay. Yeah. I know who he is. Rob Reiner.
That's him.
He writes on the side. He writes scripts on the side. No, okay,
Yeah, that's him.
But look, these are good guys. They're not going to lead you. They're not going to lead you wrong. Stick with them. Anybody who's telling you right now, "Oh, you've got to do surgery right away and you don't have time," they are probably as intimidated by the 9 cores as we were when Eric came in and said to us, "We got 11 out of 12 cores," and we had to convince ourselves here in the ANCAN group that was fine. And so we went to some of the very best surgeons in the country, and we said, "What? How would you deal with this guy at Centers of Excellence?" And they came back and they said, if it's truly 3+3 and we know he's 3+3, he's good. And in your case, you got a little bit of 4. And
5%.
and so get those slides reread. See if you can't. That's really important because with so much cancer, there's room for error, and you need either Epstein or Zhao to cast their eye over it. It's your insurance will probably pay for it, but even if they don't, it's worth it in spades for them to cast holy water over that much with a lot of cancer.
Okay,
Thank you. That could change things.
Second
Thank
opinion,
you.
100%.
Thanks, guys. Appreciate it.
Any other questions for us? BJ, any other questions for us before we move on?
Does anybody have any questions for BJ, more to the point?
Thank you.
Anybody want to ask BJ anything? Go right ahead, gents.
All right, Gary, who's next? Do we have? I think that covers all the yeses.
Yeah, well, Joe in Victoria wanted to say a little bit about since I believe
It,
we are designated as the BPH group, although we don't have
Yeah.
as much knowledge as I would like to have. Joe, I'm curious myself because we had
And
someone.
hold on a second, Gary. Did you notice who snuck in at the bottom there?
Oh, not Mr. Greg Burns. Look at this. Aha.
where is he now?
Yeah. Where are you now?
I'm in bed.
Now that's pretty sad. I don't mind saying it either. That's friggin' sad. What time zone are you in?
It's 9:30 in the morning,
Where the hell are you?
Singapore.
There you go. There you
Wow.
go. See, he's. Well, have fun.
But I do have I would like a question later if there's time.
All right. Okay, Greg.
Thank you.
Since you were in bed and you're calling on your Ancan brothers, we'll have to make the time. But Joe, we had somebody a couple of weeks back with this HOLA procedure that was really happy with it. What was your take on what they said?
Well, you're talking about Scott, right? His name's
Yeah,
Scott.
yeah. Scott
I
told.
actually, before this meeting with, so, my situation, I'll give it really briefly, is I'm a grade group 2 with a large prostate over 100 cc's and fairly high, urinary symptoms, I guess you call it, lower urinary tract symptoms. So I've been kind of looking at, I'm staying on active surveillance for the time being, and I was looking at getting treated. I'm taking both the finasteride and the what's the other one?
Flomax.
Flomax and finasteride, and they help to a small degree, but really I haven't had much success at waking up at night and urgency and all those other bad effects. So anyway, I called. I learned a little bit about it's really doing a TERP with a laser. This is what HOLEP is, and they have some capability here. I'm living, though I'm an American citizen, I'm living in Victoria, BC, and they do have a person locally who's done quite a bit. And I'm seeing a local urologist who can swear by this guy and has that many patients to him. So I'm thinking of doing a consultation with him. But I spoke to Scott about his experience, and I kind of ran it by the urologist, and he thought it made sense, except for the one thing. Scott was told that the surgery was 60 to 90 minutes, and after he talked to his surgeon, he said it was 3 hours, which I say that's a long time to be under. So I was asking about that, and he goes, "That's long." This urologist thought that was really extraordinarily long for a whole. But I'm just still considering it, and I'm going to talk to a surgeon about it. The other advantage too, if things, as part of my plan B, if my cancer has been very stable, but if it progresses at all and I have to get treated, it will give me more options on the radiology side of things, because right now with restricted flow, any kind of they have to be very careful about that. They don't. So. And I'm also hoping it might actually take out the cancer, because all my cancer is very close to the urethra where they're going to be hollowing out, and and it's kind of centrally located. And basically, when they do this procedure, they hollow the entire inside of your prostate out. You're basically just left with the shell, and my shell doesn't have any cancer in it, so maybe it could be a curative. This is my own theory and probably not true, but you know.
Well, I'll back up your theory with my doc up in Jacksonville in the Mayo Clinic. I mentioned BPH to him, and he came up with the HOLUP and said, "Oh, we have two guys here that do it." And he tried to show me, like, you take an apple and you take the core out. And he said, because my gland is 87 now, which is getting bigger and bigger. So not a good thing, but my MRI was good. This is BPH is different than prostate cancer, big difference. So, and he said the same thing. When they take out all that tissue, you have a good chance of the cancer going away. And of course, the gland coming down to a very small size. Like Scott went down to what, 20 grams, I think, something like that.
Yeah, I have his notes in front of me, but I mean the notes when I called him, and he was 80. He was about 80 and went to a 30 or something.
Yep, something like that. Yeah, 20 or 30. So, and that is an advantage. And if you actually know that your cancer is located in those areas, there's a good shot that the next time around with an MRI or whatever, they might not see anything. But he explained it the same way. So, and that was from, like I say, that was from Dr. Gundy and up at the Mayo in Jacksonville. He explained it the same way. There's a good chance of course, the size.
Yeah, and I understand they hollow out. I mean, they describe it as a coring, like you said, and other people
Right.
describe it as just taking an orange and only leaving the skin on, which seems to be very little volume left after, very little of your prostate left after.
Well, I don't, I have to research it more myself, but the coring part, that definitely seems to be what they're doing, and the gland will definitely reduce in size, and there's a possibility of the cancer going away. That now, do they
And
do
if it
pathology?
doesn't, and I progress on, and my thought is, if it doesn't, and I progress on it, it'll be easier to radiate because I won't have any, I won't have any flow restrictions at that point around the urethra.
Yeah.
So anyway, that's just my thinking, and I just thought.
Well, do a little research, because I'm sure there's. I did read somewhere there's a couple of downsides to just any of those types of procedure. I didn't get into it because I'm not contemplating that right now. But as with anything, it's got a big plus side. Like I say, lower volume for the gland, and there's a chance that the cancer will go away because it'll be gone when they do this procedure. But there was some other stuff that that could happen on the other side of the fence, which with every procedure, that's the way it is. But
Yeah, they said there's very low risk of ED, any of the prostate, doing a RP, radical prostatectomy.
Right.
Very small chance of urinary problem. Although, Scott had a complication though. He did have a scar tissue form, and he had to have a balloon treatment where they had, he had to have a secondary treatment after several months, after 8 weeks, he said, after the surgery. So, I mean, it's not all smooth sailing, but he said it was pretty successful, and he basically was a month out of whack, and then.
Yeah, and Scott's a lot older than you are.
Yeah, I don't know how old. I didn't. That's the one thing I didn't find out about him, but I didn't ask.
I have to go back in my notes, and they must go back from last year, but I'm thinking mid-70s.
Yeah, he is older. That's right. He did talk about that. Yeah,
I'm
he's like 77
I'm
or something.
thinking mid-70s, but I'd have to flip
he's a
through
bit
all my
older than that.
pages to figure it out.
But
okay. Well, keep us posted, keep us posted, and I have a special interest myself. I see that Derek would like to say something.
Yeah, I just want to say, Joe, in regards to your concern with sedation or anesthesia, my Whipple procedure at age 63, 3.5 years ago, I was out for 9.5 hours on the table.
Wow.
And I'm here to talk about it. So, yeah, the anesthesiologists these days are, I guess they do their work well. The other thing I wanted to mention was you brought up Flomax. That was mentioned in Captain Jim's article about flunking a PSA test, and that is one of the medications that can artificially inflate PSA numbers.
Okay.
It's actually, I think it's the finasteride that does. Oh,
Yeah.
Flomax?
Tamsulosin.
Finasteride's done.
Tamsulosin. That's
Tamsulosin.
Flomax.
I never heard
He,
Flomax.
Well, they
he
make
listed it as what is it?
Tamsulosin.
Tamsulosin, correct. Is that not Flomax?
I
It
didn't
is.
know that. I didn't know that it could raise it. I know that I'm taking finasteride, and they double the number. Like I also got a PSA test of recently, and I got a 4, which is pretty good. But they double it to an 8. Just because you're
Yeah.
taking finasteride.
Yeah, you got to double it if you're on finasteride. As I said, as you research it, please come back, and I have some interest myself that I'd be curious to know what you find out. Okay.
Okay.
All
I'll
right,
keep
Joe.
in touch. I'll let you know. I'll let you know personally. What I get. My
Joe,
notes on it.
Joe, I posted a video that you might like from Dr. Schultz in the chat for you.
Okay. Thanks.
Excellent. Okay. All right. Well, we're running out of time, but since Greg is in Singapore, and anybody who knows Greg, we never know where he's going to end up: Bali, Singapore, here, there, wherever. And he's laying in his bed. So go ahead, Greg. What do you got?
Thanks, guys. Yeah, listen, I just, for the first time, got my Decipher score. I don't know why it's taken so long to get it to me, but the sample was taken in December 2023. They received it in 2024, but I've just literally received the information last month. So I'm just curious what you guys think of these numbers. So I have GPS is 18. Does that make any sense to anybody? And then I've GPS is 18. And then I have a likelihood of adverse pathology at radical prostatectomy, 29%. So I'm in the moderate likelihood department, low on that. And it says this patient's likelihood of adverse pathology, at radical prostatectomy is 29%. Based on the combined GPS result and the NCCN risk group. Anyway, any data from the clinical validation study suggests the patient has a moderate likelihood of adverse pathology compared to other patients in the clinical validation study. And lastly, it says in our clinical validation studies, 43% of patients with NCCN favorable intermediate risk prostate cancer had adverse pathology at radical prostatectomy. Any thoughts on what that all means?
Did they give you a Decipher score?
Yeah, I believe that's the 18.
0.18?
No, 18. Okay, point. No,
It should be.
That doesn't sound right.
Should be.
Okay.
The number is between 0 and 1. I think.
0 and 1. So where are you on that scale?
Okay, 0 and 1 on that scale. Okay, I see a prostate volume is 21, density is 0.22, number of cores 6, number of cores collected 17.
So density.
That's a biopsy report.
Right. Okay.
Not a Decipher report.
Okay. Let me go back to the other page. So just say, okay. So the Decipher score.
It should have a chart and have high risk levels, 3 risk levels, and
on the left side
arrow
of the
pointing
page
to where you are.
should show a Decipher score and a scale and where you are on that scale.
I thought that was the 18, but maybe I'm wrong. So there's a high grade disease, Gleason, adverse outcome, non-organ confirmed adverse.
Should actually be a number. It should be a decimal
maybe
point
this is
number.
not. Maybe it's not a Decipher. This is a genomic prostate score GPS report. Is that not a Decipher?
That is not a Decipher.
No, that's not.
Sounds like a promise.
Okay.
Possibly.
Interesting.
No.
Okay, so this is not a Decipher.
The fact that it took you a year and a half to get it back, that's a little fishy to start with, for sure.
Okay.
That's kind of crazy. And that, no, Decipher would actually say Decipher score, and it would be on a, they would give you a chart, like a scale. And
Okay.
So for those that don't know, can somebody explain the Decipher test?
I'll take a stab at it. They you
Oh, thank you, Tom.
they take the core that has the most cancer. They look at the cells and they grade that based on other past prostatectomies. So it's slightly older data, and they grade you on how aggressive your cancer is. Does that sound right,
but
Kerry?
they actually base it on people that had a radical prostatectomy.
Right.
Sure.
That data is based on people that had the most severe kind of treatment, which I'm just not technical or scientific enough to figure out what bearing that has, basing it on people that, I guess, on an autopsy after they're after they take out the gland, they do like an autopsy and find out exactly how much cancer was everywhere. So I guess that's what they're basing it on.
And the end result then is a percentage of your likelihood, I believe, right? To
Michael,
get,
do you have something on that Decipher? You're muted.
I was
Can't
going to
hear you.
say, not so much on the Decipher, but he was using the word GPS. So there are several tests out there: the Decipher, the Prolaris, the GPS, the Artera AI. I think it's just we stress the Decipher so much here because that is the test that the NCCN now approves or considers to be the best test. It sounds like you had a GPS score and not a Decipher, which is
Correct.
another test that does things similarly. I don't know anything about a GPS. I have never looked at one. I've looked at Deciphers and I've looked at Prolaris. So I'd have to look up GPS. I think it's
So
a good test, but it's not the one that NCCN recommends now. I would
well,
say that.
I don't know about that. I wouldn't say it doesn't recommend it. I think GPS is the Oncotype DX test.
Yeah, I
Who,
think you're
who,
right. You're right,
Okay,
Gordon.
who's
Greg, I'm gonna let you. Greg, I'm gonna let you go to sleep feeling good. I've got GPS and NCCN individualized risk. The score ranges from 0 to 100, with scores closer to 0 representing lower risk prostate cancer disease potential, and those closer to 100 representing higher risk prostate cancer disease potential. So if you got an 18, you're like in the low side. That's a good
Yeah.
Right.
thing.
Okay.
so the Oncotype is a very solid test. It's comparable with Decipher. It's comparable with Polaris. It's comparable with I don't know what else. But it's one of the older and one of the three main ones. So and I would say you're right. 18 is a good score on it. I'm not great on these tests. I really am not. Can't tell you, and I can't really tell you the difference between each one. Dr. Mark is a little better. So next time you go to low intermediate, ask Mark about Oncotype, and he'll give you the pros and cons and tell you about all the other different ones you can get. But that's what it is. Poor Martin is totally puzzled. He's never heard about what all these tests are about before. In a nutshell, and we can't really get into it today, and there's a lot of stuff. You can go to our website and put Todd Morgan. Just put in Todd Morgan and it'll show up. Put it in the search box and you'll hear a webinar from Dr. Morgan a year or so back that explains Oncotype and all these different tests. But essentially, what they do is they send out a sample from your prostate, and they do an analysis on that sample to tell you likelihoods of different things. How likely your disease is to progress. If you have surgery, how likely you will need surgery. I mean, there's so many different. There's a 4K score. There's so many of these scores, and I just don't know them all. Somebody here in this group should. Phil has his hand up, so he's going to plunge in there. Go ahead, Phil. Unmute, please. Unmute.
Phil, I'll do it.
Phil, unmute. No, you're muted again. You unmuted and muted right back.
Okay, here I am. Unmuted.
Yes, you're there.
ASPE did a webinar, I think, last month on biomarkers. That's well worth listening to.
There you go.
I listened to that too, Phil. Dr. Tawari from Huntsman Cancer Center did that. Now I will say, when he gives his talk, he admits he's supported by Myriad. He shows some favoritism towards the Prolaris in active surveillance. Inactive surveillance, not
right.
So
this is and Michael, this is always a problem, and we go back and forth with Myriad because they want us to push their tests, and we say we don't do branded. And when we asked Dr. Morgan to do this webinar for us, it was on the understanding it wasn't going to be branded. And so that webinar that Eric just put in, that's definitely a good one to watch. Do you have your hand up again, Phil? Did you want to say something else?
No, sorry, I'll take it down.
Oh, it's okay. All right. But these are basically tests that when you are at a certain level, and it may be a little early yet, but it may not, Martin, that these are tests that your doctor can order to tell you how aggressive your prostate cancer is going to be, or how likely it is you'll be able to remain on active surveillance. And each one of the tests tells you something slightly different.
Okay, that's great. Thank you.
I think Dr. Schultz uses the term sometimes they can be a tiebreaker if you're looking for one.
Yeah.
Okay, I like that idea.
It's just another set of numbers that completes as part of the whole puzzle. You can't just look at the one and say definitively. You've got to use them all and then come up with the diagnosis after that.
Yeah, Greg, if you Google just GPS prostate cancer, you'll get that information about that test, and they've got some samples of the graph and all the rest of it. But it's zero to 100, and you're good. So
Eric,
I read that earlier. Thank you for repeating it to me. But I was just curious if I didn't. I thought it was the Decipher score. Now I'm just
completely different test. Different company, different. Yeah, completely different.
Got it. All right. Thank you.
Hey guys, real quick. We're getting close to the end here. I want to point out in the chat at the top there's the vertical dots. You can save the chat to your desktop or on your phone. We put a lot of links in there, so you may want to save these. So definitely do that before you leave. Otherwise, you'll not see it. So save.
Thank you.
Okay.
All right. Without further ado, I think we should wrap it up. Does anybody have any last minute questions or whatever? We are running behind schedule here, so.
Can I make a comment? Before I discovered you, I kind of was exploring in Facebook and other social media, and I see hundreds of people making all kind of comments and all variety. I see some other doctors also participate. What would you say to some people in those groups? Why are they not here, or why people just exploring everywhere and not going to people that specialize in this? So what would you say to any of these people?
That's why you go to groups like this.
Right. So Thank you for. I'll answer that very quickly, and then we all want to go. I know we all want to go, but I'd like to say this. We think that we have a better mousetrap here for a bunch of reasons. One is because we don't spend a lot of time talking to everybody in the group and checking in with them and seeing where they are this week versus where they are last week. We could spend the whole time. Secondly, we make sure everybody gets to talk. Thirdly, we do our best to have people that are very knowledgeable as our moderators. Fourthly, they are all peers. So we're not run by social workers and goodness knows what. And nobody says, oh, you can't say this or you can't say that. So there's a whole bunch of reasons. Why don't more people come in? I can't tell you. I don't know that. In a way, it's good because we get quite a lot. We didn't have a huge group tonight, but we can often get 20 in here. We don't really want that. We do record the group now, so other people can do it. Send people, Andre, feel free. Send them to our YouTube channel and let them watch. And if they like what they see, they'll come on into the group. But I mean, Gary, when was it? About 4 or 6 weeks ago, you had 6 newbies one day.
Yeah. Oh yeah, that was fun.
Yeah.
That was fun. Yep. That was
So you have to be careful what you wish for, Andres.
Well, thank you very much.
Hey, Andres, it's the end of the meeting, so I can say, I get dispensation. How about that 3-0 result last night, eh?
It was awful, awful. I hated it.
Oh man, I've never ever. Well, you guys are going to drop off now. We'll stop recording.
Recording.
We'll stop recording.